Next 30 minutes, soft tissue infections, from very simple, very basic abscess care to more complicated issues in terms of picking up the critically ill ones. It sounds like it ought to be easy to find those very sick patients with necrotizing fasciitis, but I can tell you no diagnosis comes to morbidity and mortality more over the last 20 years at our hospital than necrotizing fasciitis. So, if you want to talk about death and donuts, the other name for morbidity and mortality, if you want to talk about death and donuts, it's all about soft tissue infections. So let's jump in. You'll see everything from these little furuncles to a raging cellulitis to sort of these abscesses, which are obviously fluctuant and pointing, and we're going to jump in and talk about these. If you're trying to determine if it's a cellulitis or if there's an abscess underneath that, a lot of times it's really easy. You don't even suspect that there's an abscess. It's a relatively smooth area on their lower leg. It's obviously an ascending cellulitis. But when you get to sort of fattier areas, it's on their abdomen, it's in a gluteal fold, it's in a portion of their upper torso. Sometimes it's not so easy. It'll look like a cellulitis and you won't be sure if there's an abscess underneath that. And over the last couple of years, there's been a whole bunch of papers that say, do something really simple to answer the question. Don't guess. Don't pretend that poking it for fluctuance is a scientific evaluation. It's not. Put an ultrasound on it. And what you'll find is underneath these big thigh abscesses, under this big thigh cellulitis, under this big lower back cellulitis, you'll find a pocket that you couldn't identify just by palpating it. And then you'll know where to IND the abscess which is underlying it. So ultrasound, looking for the abscess, looking for a fluid collection, looking for a drainable source of infection under a large cellulitis. I think that's really quickly becoming, I hate to use the word standard of care, but really ought to be something that you're contemplating. And this is something you can do yourself, easily learned, really simple. Now, IND remains the treatment of choice. When you find one of these pockets of infection, you should drain the pus, because that pocket, if you put them on antibiotics, it doesn't get into the pocket. So it's not going to go away. So you have to drain an abscess. And most of them are relatively simply drained with just local anesthesia or a little bit of procedural sedation and then opening it up. I would also note that in this era of MRSA, I'm often talking to the residents, they've drained the abscess, and I go, look at what they've done, and I sort of look in there, and there's all this sort of fibrotic, necrotic stuff that's still in there. And I have to tell them, no, it's not just IND, it's IND and D. Incision, drainage, debridement. Get your French out. You got to take that crap, that necrotic fibrous stuff out of there, because that's also harboring lots of bacteria, and it won't get better if you leave that in there. So particularly with the furunculitis that you see with MRSA, they got the multiple little pockets. You got to clear that little knot of tissue that's out that's in the base of that. So if the patient's toxic, febrile, then you got to consider about working them up, labbing them up, etc. And most abscesses, like I say, pretty simple to drain. Where should you be a little cautious? Where there's a lot of cosmetic issues, right? INDing the huge unicorn abscess on the front of their head, you might want to think about that. Breast abscess is sometimes, particularly if it's encroaching on the nipple, is something that you might want to consider having a surgical colleague get involved in. Axillary abscesses, where you're worried about vascular structures nearby, even occasionally an antecubital abscess can get you into trouble with the venous structures that are there. So know your anatomy, but proceed forward in most cases. Bupivacaine versus Lidocaine, we've had lots of discussion about this over the last couple of days, and the relative equivalence is 0.25% bupivacaine equals 1% lidocaine, the 0.5% equals the 2%. Bupivacaine's a little slower in onset, it lasts quite a bit longer. Here's a table that's actually kind of ought to be posted around, because as simple as these are, and as often as we use them, it's easy to get cavalier with them sometimes and forget the upper limits. So the maximum dosage column is what I want to draw your attention to, and you'd be surprised how easy it is to go over it if you're numbing up several things, or numbing up a large laceration, or numbing up a big bunch of road rash to try and clean it out. It's easy to go over the max, and I'll just tell you, when you go over the max of lidocaine, it's not good. They'll either get behavioral problems, they'll get agitated and then seize, or they'll start having dysrhythmias on you because, as you remember from basic medical education, all antiarrhythmics are pro-arrhythmic. So if you dump a bunch of lidocaine in there, you might be rewarded with something like VTAC or VFib if you go over the top. So these upper limits are really worth noting. We post this in our department because people get cavalier about it and they don't realize if you draw up a 20 cc syringe and fill it with 2% lidocaine, you're pushing the top. You're pushing the top. Notice that it changes when they're with epi because the absorption is slower. So the numbers are 4 and 7. 4 mg per kg with plain and 7 with epi. You can warm them, you know, for a period of time in the medical literature, it seemed like every resident and every junior faculty in the country was publishing things about how to make lidocaine less painful. And that's all common sense. Use a smaller needle, that hurts less. Go through the open wound rather than through intact skin, that hurts less. Warm it up, make it at room temperature, store it in a pocket so it's warm. Buffer it, there were all these things, and that was all true. So buffering it works, warming it works, and using a smaller needle probably is the most important. And then injecting through, you know, anytime you're going to use these, you should be able to inject one area, raise up a wheel that's going to numb that area, and you should advance to do the whole rest of the anesthetic through that area you've just numbed. So you shouldn't be then moving to the far side of the wound and poking them again. Extend towards it and work from the anesthetized to the unanesthetized area. And here you go, 27, 30 gauge. 30 gauges bend a little bit, so if you're doing a larger area, you got to keep that in mind. Go slow with the injection, avoid multiple sticks. All right, linear incision, usually adequate. You should follow the parallel skin lines if they're discernible. You could open up you could get on the web and say, you know, look for the skin lines, the normal skin lines, and you could find out what direction they're supposed to go on any portion of the body to help you think about this. And that will help with what you're doing. Drain out the pus, break up the loculations. I see people hesitant to do this because the patient's in pain, but an inadequate IND is doing nobody a favor. And then if the abscess is caused by a foreign body, that's, by the way, another reason to ultrasound it, looking for foreign bodies. And you should x-ray if you're worried about glass. Remember that glass, it used to be said that you only see leaded glass in a laceration, but there were a bunch of studies done, some of my favorite, where they took pig feet and they embedded them with glass. The pig's feet were off the pigs, just, you know. They didn't hurt the pigs, we ate them. Then we took the pigs to the feet to do the research. And they find that all glass, leaded and otherwise, is visible. What determines when you stop seeing it is how big the piece is. So once the piece of glass gets small enough, at around 2 millimeters, where it starts becoming a small little shard, like one of those ones you stepped on the kitchen floor after you thought you swept up the broken wine glass, one of those you can't see. So at 2 millimeters, they start becoming hard to pick up on x-ray. Anything less than that, you have about a 50-50 chance of seeing. But get the foreign body out. If you don't get the foreign body out, the infection will persist. Culture? No, usually not. It's expensive. The culture and then sensitivity costs 10 times what the therapy costs, even if you're going to treat them with antibiotics. Packing, you could pack them. If you really think the wound is going to fall closed, then packing has a reason to be there. You know, this idea that packing is like a cargo net for the bacteria to climb out, you know, it doesn't really work that way. But loose packing is fine. Most of the literature says packing does not matter. And certainly don't repack something. I see that happening. You know, first person packed it, the person comes back for a wound check, and now we're repacking it 3 days later. They're getting better. I'm like, no, probably the first one wasn't necessary. Certainly the second one isn't. Update tetanus for sure, and then follow-up. You want to see where these are. This depends on your local custom, how good your follow-up is, what kind of doctor they got, whether they can get there, what time of year it is, all of that stuff. Impacts whether you can get follow-up for these. All right, antibiotics. So generally speaking, if they have an abscess and you IND a good pocket of pus and you've done the second D, which is debridement of the dead necrotic stuff in there, you're done. They don't need antibiotics. There will be a rim, an expected rim of redness around an abscess. It's a couple millimeters up to a centimeter. That's not a cellulitis plus an abscess, that's just an abscess. Now, if they have, in addition to that, a lymphangitic streak or a cellulitis going away from the abscess, that's evidence that the bacteria set up shop, they made an abscess, and then some of them have left town. So if there's a lymphangitic streak or an abscess trailing away from it, cellulitis trailing away from it, that cellulitis is a reason to give antibiotics, but the abscess that you've IND'd is not. So we'll get to the actual Infectious Disease Society recommendations in a moment. What are the causes of abscesses? MRSA is now the most common cause across the country. So if you are going to give an abscess, you need to give, double-strength Bactrim. You can go with Clinda or Doxy. I would remind you that Clinda has some problems with it, right? It's expensive, it's less well tolerated, it's associated with C. diff, and furthermore, almost all of the clones, if you look at the genetics of the existing MRSA across the United States, are Clinda inducible. In other words, before you even put them on Clinda as an antibiotic, they're ready to become resistant to it. So if you use Clinda a lot, which we did initially at LA County, then what you find is you'll get to 75% resistance to Clinda within like a couple of months. If you don't use Clinda a lot, your resistance will be there, but be advised, for Clinda, they are inducible for resistance. It's still in their recs, though, the IDSA. All right, when to culture. This is actually sort of the bottom line here. Much ado about nothing, but when to culture? Generally not. But if it's severe local infection, signs of systemic illness, poor response to initial treatment, so you're thinking there's a new resistance pattern you haven't figured out, or there's some cluster of outbreak and you need to know what it is. What is the cluster? Those are the reasons to culture. When to give antibiotics? There is an extensive cellulitis, an ascending lymphangitis, or they're immunocompromised. Multi-site abscess, rapid progression, extremes of age, difficult to drain areas, so you think your drainage might be incomplete. Associated septic phlebitis, you can't debride a whole vein. So if they've got a septic phlebitis with it and an IV drug abuser, it's not like you can strip the veins of their forearm. They're going to have this source of infection ongoing. So septic phlebitis needs treated with antibiotics, or a lack of response to a previous IND. The good news about the IDSA recommendations here is they're pretty common sense based. I don't think you need to post this. I think anyone with common sense who's doing any medicine would figure these out. There's nothing that comes out of left field on this list. It's all common sense. All right, cellulitis, usually caused by a break in the skin, and the #1 cause of cellulitis in the country is athlete's foot. You don't think of it that way, but all your diabetics who are chronically fungally infected have fissures and cracks in their feet, and eventually some bacteria that are normally colonizing their skin get into one of those and set up an infection in the subcutaneous tissues and in the skin, and they have cellulitis. Staph and strep are most common. They respond usually in 7 to 10 days, and here's some drugs to consider. But when is a cellulitis not a cellulitis? It's when it's decided to go deeper than that and is causing problems. So we get to this thing in emergency medicine. It comes up all the time. Poop. And when there's poop, you got to think twice. Let's talk about some of the diagnoses that have poop. Pain out of proportion. So neck fash is a poop diagnosis. Compartment syndrome is a poop diagnosis. Acute angle closure glaucoma is a poop diagnosis. The list goes on and on. Mesenteric ischemia, when you got a whole bunch of dead bowel, is a poop diagnosis. Pain out of proportion is something that if you work in an emergency room, because we're in the business of collecting people who are sicker than average, right? Emergency department patients are sicker than those that go to the clinic, are sicker than those that go to the office. And so we are a center of excellence of poop, because when you're sicker than average and it really hurts, you're going to go somewhere for an unscheduled visit to find out what the poop is going on, because you can't stand it anymore. So they come to the emergency room. So poop is our business, and when poop is present, you got to respect it. And with soft tissue infections, when poop is present, neck fash is what you're worried about. We'll get to that in a moment. This is Erysipelas, the butterfly rash, or the sort of purple violaceous, well demarcated. Almost looks like the woman on the top has, you might say, lupus, or maybe even the sharp demarcation of that erysipelas on her upper eyelid. You might even think she was punched a week ago or something. Look how sharp the demarcation is. Responds to the usual anti-strep antibiotics. Impetigo, honey-crusted. It can be bullous. If it's bullous, it's probably staph. If it's a small area, then topical antibiotics like mupirocin work just fine. Once it gets to be more, what's the limit for mupirocin? Most people say if it's greater than 3 by 3 centimeters. If it's more than that, then you're kind of out of the mupirocin alone treatment. You can give them mupirocin still, but you'd better add an oral antibiotic once it's more than 3 by 3 centimeters. Diaper dermatitis. This is, in the United States, what we think is the cure for otitis media. Because we give these kids with otitis media who don't need antibiotics, we put them on antibiotics and then they shit their brains out and then they get this. Now the kid has a real reason to cry. And the treatment for this is, it's usually fungal. It's very irritating to the kid. When you see one of these, you take the diaper down and you go, you know, your heart reaches out to that kid. You're like, oh, that looks uncomfortable. You know, you can't even imagine having what they got on their butt for 5 minutes. So you're then going to treat this with a topical clotrimazole. You might give them some steroids depending on how much pity you have. And then you're going to remember some of the first rules of dermatology. If it's wet, which this is from wet feces from the diarrhea that you got from your antibiotics sitting on your butt. If it's wet, dry it. And then the other rule is if it's dry, wet it. And then just while we're on the topic of the basic rules of dermatology, the last rule of dermatology, which is really the most important one for anyone who works in an emergency room, is this. If you know what it is, don't touch it. If you don't know what it is, don't touch it. Either way, why would you touch it? Because I remember when I was an innocent young intern doing things like that and touching things, not always with gloves and poking stuff, and then you realize, oh, those lesions were teeming with syphilis. Or a day after a call, right, pus starts coming out of your eyeball and you're wondering, oh God, what did I touch? I remember rushing back to the hospital from the beach when I was an intern thinking, because the pus just kept coming out of my eye and I was on jail. So I was thinking, oh God, it's gonorrhea. I got, you know, some jizz surface area, eye contact, something. Now it grew out H flu. So I was very relieved when that happened. But anyway, you know, don't touch it. And this is for this one, if it's wet, dry it. So this kid needs to have their butt placed in a fan and their diaper taken down, and they need to be splayed out for the world until this, because the fungus doesn't like growing in a desert. If you go to Palm Springs, there's no fungus. All right, now we're on to the neck fasc. So easily to misdiagnose. It's so easy to underestimate it. It's so easy to get it wrong. And then on top of that, when we do get it right, we call the consultants, and let's see a show of hands. Make everyone happy here. Tell the truth. Who's thought it was neck fasc, but the consultant said, oh no. So then the consultants come down and try and get you to do the wrong thing and send it home. So even when you call for help, they don't believe you. So it's hard. And it can be a true surgical emergency, and it's hard to convince men with knife to take them to the OR. But you'll try. So these are some, you can see these things that should make you think of it. Bullous changes, if they have that bronzing. If part of it hurts more than it should, and part of it doesn't hurt at all, that's because they've necrotized the sensory nerves in one area. If you see that weird thing where the leading edge of the thing hurts like more than it should, but you get back over the actual infection and it doesn't seem to hurt there, worry a lot about that. If you find a low sodium that has no business being there, now we're getting into what's called the Elrinic score, but a low sodium in one of these patients should alert you. A white count that's high, you thought it was a simple cellulitis, and then you get the labs back, white count's 29, sodium's 129. That's neck fasc. Look at that thing again. Call a surgeon. Because even if the surgeon won't take them, at least you need to put them on the hook and say, I asked you to take them, because these people get amputated and some of them die. It's bad, bad condition. So they may have this restlessness and tachycardia. Now, the tachycardia, right, you expect someone sick to be tachycardic at like 110, 120, and you're giving them fluids. But sometimes you're looking at them and they're tachying at 140, 150. And what that is there's a cardiotoxin being released. In addition to their sickness, this cardiotoxin is driving their tachycardia. Happens with Clostridia species quite a bit. They may have labile indifférence, which means it's sick and they're obviously dying and it looks like body parts are about to fall off, but they're like, yeah, doc, it's been like this. I'm okay, though. You know, when can I have, like, lunch? I'm thinking of catching the bus home. You're like, yeah, you're thinking of catching the bus to the hereafter. That's the only bus you're catching. But they seem to be looking good about it, and you'll see that. And call a surgeon, as I said, high mortality rate. Now, SIRS, sepsis, and severe sepsis, we're going to go through these. So SIRS, you have 2 or more of the following. And our charts now, because of the sepsis, surviving sepsis campaign, I'm sure many of your hospitals have something where they mark these patients out for you. So when they get anything like this, the chart, the computer automatically flags them red. And then you have to say, they are a sepsis candidate or they're not. Because you can have these things without having sepsis, but they want you to think about sepsis whenever any of those vital signs are present. Now, sepsis is when you have SIRS plus an infection, right? You could have SIRS without an infection. You could have SIRS with lupus. You could have SIRS with rheumatoid arthritis. You could have SIRS with some other autoimmune process, but you don't have an infection. But if you have SIRS plus an infection, that's sepsis. Severe sepsis is when you got SIRS, you got a source of infection, and you got an organ that's saying help. Some organ is dying, so they need to be intubated. That's not good. They got a creatinine that's over 2. The kidneys are saying help. They got a coagulopathy with an INR greater than 1.5. That means they're sort of thinking about going into DIC. I got a bad infection. It's running around my bloodstream. I'm thinking that rather than die of respiratory failure, maybe I'll die of bleeding to death from DIC. They got an FiO2 requirement of greater than 30%. That's like the intubated one up top, so one of those. And why do they need intubated? Why are they having respiratory failure? It's because their acid, usually, not always, but usually it's because their acidosis is so severe that they can't breathe. Remember, the main way you eliminate acid from your body is by breathing. And if that acid load exceeds your respiratory ability to deal with it, then they get intubated. Remember, when you intubate those patients, that you need to set the ventilator rate in a way to optimize their ventilation. If you underventilate a sepsis patient when you intubate them, you'll kill them because their pH will go from 7.1 to 6.8 in 15 minutes because you're underventilating them. So it's quite important. And then finally, the last in the cascade is septic shock, where you have severe sepsis and now your blood pressure is low or your lactate's greater than 4. Lots of places are doing probably way more lactates than are needed looking at these things. It's a pretty straightforward cellulitis. I get residents sending lactates on those all the time. That's unnecessary. But when you're in this realm where the patient looks bad or you're thinking that there's poop available or it looks like this patient may be sicker than you think, then a lactate certainly ought to be added to that. So what's happening with sepsis? We've learned that if you do a good job with sepsis, it gets better. Does this mean you have to do the whole Manny-Rivers protocol and bundling and all of that? We're beginning to break the Manny-Rivers protocol down and learn what matters. And what seems to matter most is more volume than you thought was necessary. That 1.5 liters isn't enough as a resuscitation for them. They need 6 liters. They need 8 liters. So more volume in their resuscitation is one of the things we're learning. The second thing we're learning is it actually matters because a lot of these people get to the emergency room just before they're about to go over the cliff, and early and appropriate antibiotics matters. And as you could gather from what I just said, if I was going to add a third thing, appropriate ventilator management matters. If you're going to intubate them, you need to manage them appropriately. So, approach, vitals, Start looking for SIRS. Get the lactate levels if they're sick. Blood cultures and appropriate cultures from the source if they're sick. Antibiotics tailored to the suspected source. Fluid boluses. The first one ought to be 20 mil per kg at a minimum, and our hospital makes us do 40 mils per kg, which I think is appropriate. You got to ask, does the patient have failure? But in the absence of some cardiac disease, we're going to proceed with 40. Consider a CVP line. I think that's one of the weakest of the recommendations. It was part of the Manny Rivers protocol, put in that Edwards catheter and the whole thing. I think that that's association with improved output is the most, improved outcomes is the most tenuous. And then if a patient needs vasopressors, you know, you'll hear in your institution that they love norepi, or they want you to do dopamine, or some cardiologist wants you to wade in with some dobutamine. Here's what we know about pressors. Let me summarize everything we know for sure. Okay, there we go. All right, we don't know shit is what I'm trying to tell you. So no pressor has ever been proven to be superior to any other pressor in any other circumstance. Now that doesn't mean we don't think that there might be areas where one is better than the other, but really these are a product of the culture of the institution you're working in. So if they love norepi, how many are in a norepi-loving world? Most are now. I'm in a norepi-loving world. Fine. If that's what they love, then fine. The updated guidelines, Society of Critical Care, continue to advise early goal-directed therapy. That's with the central line and with the central venous measurements, et cetera. Use of procalcitonin. There's a lot of peds literature telling you to get this procalcitonin. Do we really need another non-specific marker? We already got the white count. That's one non-specific marker. We already got the platelets. That's another non-specific marker. We already got the lactate. It's another non-specific marker. We already got the pH. We got all those non-specific markers. Do I really need procalcitonin? No, I don't. Although they want to pretend that there's something important about the procalcitonin in kiddies. You may be hearing this. I believe they're largely full of shit. Okay. Here's the goal-directed protocol. You've seen it before. And in terms of fluids, crystalloids, initial challenge of 1 liter. Here you can see they're going minimum 30 mils per kg. I told you we're 40 at our hospital. Albumin in severe sepsis, weak recommendation. In fact, most of the literature says albumin makes them worse, except, at least my read of the literature, is the only place albumin's been proven to help is when they have hepatorenal syndrome. It's the only place that albumin helps. Albumin, very expensive. I personally view albumin as our attempt to suck the estate dry of the last few dollars before they die. That's mostly what albumin's about. We need to get the last few dollars out of the estate because it's very expensive and doesn't make much difference. Vasoactive drugs, here's the pressors, as I said. Strong recommendations are made for the use of norepi. As I told you, I appreciate your strong recommendation. You don't have strong data, but I appreciate it. And regarding steroids, they don't work unless the person's adrenally insufficient. Then you can. Initial funding of the campaign was about 90% by Eli Lilly, and this is where we get into these things for Zygris, and so we're not doing that anymore. And there's, in the Surviving Sepsis campaign, there was this issue with the catheter manufacturer in Manny Rivers. So I put those in there just so as you know. Yeah, some of this is conflicted, probably based on financial conflicts of interest is why some of the data is what it is. All right, there you go. And Ricky's standing by. I went about a minute over. Sorry, Rick.